Our next speaker is Dr. Jennifer Rose Nussbaumer. She's going to be talking about beating back bacterial keratitis. And just as a reminder, make sure to get those questions in on the app.
Good morning. I have no financial disclosures, just a couple of NIH grants. So topical antibiotics are really the mainstay of therapy for bacterial keratitis. And in a survey that we did of the Cornea Society, we found that most cornea surgeons are using fortified antibiotics, shaded in green, either vancomycin or cefazolin. And while topical antibiotics are successful at achieving microbiological cure, there really haven't been any good studies that have shown that one broad spectrum antibiotic is better than another and has better clinical outcomes. So it's likely that inflammation is playing an important role in the scarring and irregular astigmatism that leads to visual disability for these patients. This is a confocal micrograph of a patient with Pseudomonas, active Pseudomonas, infection, and you can see that there's a dense infiltrate of neutrophils into the stroma, and it's likely that that is causing a lot of damage. So ideal therapy would address both infection and inflammation in these cases. So for the rest of the talk, I'm going to talk about what's already known about managing inflammation and keratitis. And I'm also going to talk about a pilot randomized clinical trial that we did looking at adjuvant corneal crosslinking, which is very interesting because it may be able to treat simultaneously infection and inflammation. So the steroids for corneal ulcer trial was the largest study to date to look at this relationship of treating inflammation in bacterial keratitis. It was a collaborative effort with Aravind Eye Hospital, Dr. Srinivasan, and Tom Liebman, Nisha Acharya at UCSF, as well as Mike Zegans at Dartmouth. It was a randomized, double-masked, placebo-controlled trial which randomized culture-positive bacterial ulcers to topical steroids versus placebo starting 48 hours after antibiotics. And the primary outcome was visual acuity at 3 months. When they analyzed their results, they were not able to find a difference between steroid group and placebo in terms of visual acuity, infiltrate scar size, time to reepithelialization, or corneal perforation. However, when they did subgroup analyses, they saw that large central ulcers did better with steroids. They also saw that earlier treatment in the course of disease with steroids had better results. And they also looked at all comers except for nocardia ulcers and found that those patients also, on average, had 1 line better visual acuity at 12 months. So it does seem that there is some role for topical steroids in the treatment of bacterial keratitis. Crosslinking is also interesting because it's been shown that photochemically activated riboflavin has an antimicrobial and anti-inflammatory role. And it also appears that cross-linking of the collagen fibrils stabilizes the cornea and may make it more resistant to enzymatic degradation. There's been a number of series in the literature that have been published. One of the most interesting is this one that comes out of Sweden. They treated 16 patients exclusively with cross-linking and found that all of them responded to therapy and only 2 patients required topical antibiotics, which is very surprising. So we designed the cross-linking assisted infection reduction pilot study in anticipation of a larger randomized clinical trial. This was a collaborative effort between UCSF and Dr. Prajna at Aravind Eye Hospital. We randomized smear-positive bacterial ulcers to moxifloxacin alone versus moxifloxacin plus cross-linking, and our primary outcome was culture positivity at 24 hours. We also, of course, looked at visual acuity, infiltrate scar size, rate of perforation, and the need for a therapeutic transplant. So we randomized 36 patients And as you can see, they're well matched in terms of demographic factors. We did see a preponderance of women in the cross-linking arm. In terms of their baseline clinical characteristics, they were well matched in terms of visual acuity, infiltrate scar size and depth, epithelial defect, and duration of symptoms. Most of our patients were culture positive for strep pneumonia or Pseudomonas, a little over a quarter in each group, while smear positive were culture negative. So this graph shows our primary outcome of culture positivity at 24 hours compared with baseline. And you can see that those randomized to cross-linking had 50% lower odds of culture positivity at 1 day. This was not statistically significant with a p-value of 0.57. And we feel that because it's a pilot study and we had low numbers, only 36 participants, it may be that we weren't powered to detect this difference. In terms of visual acuity, those in the cross-linking group started a little bit lower. And this is, just remind you, logMAR of 0 is 20/20. So the higher you get on the logMAR scale, the worse the vision. So those in the moxifloxacin plus cross-linking group had slightly worse vision at the beginning, but by 3 months, they also had about 1 line worse visual acuity. This was not statistically significant. And they did also have slightly larger scar sizes. So this is a patient who was in our series. She had Moraxella ulcer. And you can see that over time, she after cross-linking, she did very well. But her vision is still limited at 3 months to 2400. It's unclear if the cross-linking led to worse scarring, or as we all know, in patients with keratoconus, cross-linking initially does seem to lower the visual acuity, and then over time that resolves. With a little bit of corneal haze resolving, this patient may do much better over time. In terms of adverse events, the moxifloxacin plus cross-linking group actually had about 1/3 of these adverse events, including perforation and the need for TPK. However, it was not a statistically significant result. Again, we don't know if this is because it was a small pilot study. So in conclusion, most corneal specialists in the United States are using fortified antibiotics to treat bacterial ulcers. Steroids do appear to be safe in culture-positive non-nocardia ulcers, and it seems that there is some role for steroids in the treatment of bacterial keratitis. Adjuvant cross-linking may reduce culture positivity and adverse events in bacterial keratitis, but it may also negatively impact visual acuity. And so this really needs to be studied further in a large randomized clinical trial. And that's what we're planning to do. We just got NIH funding for the steroid and cross-linking for ulcer treatment, or SCUT2. This is going to be a randomized clinical trial that's going to evaluate adjuvant steroid as well as adjuvant cross-linking. And our primary outcome will be visual acuity at 6 months, so I look forward to sharing those results with you. Thank you to all of my collaborators, without whom I couldn't have done any of this work, and thank you for your time.
Great.